Hey everyone, welcome. So if you're gearing up for your ATI Pediatric exam, you already know that respiratory section can be a real bear. But don't you worry, because in this explainer, we are going to do a super high-yield review to get you totally prepped and ready to nail this thing.
And let's be real, it's a tough topic, right? It is just packed with all these tiny details and critical differences. But I promise you, by the time we're done here, you are going to have a way clearer picture of what you absolutely positively have to know. We're going to cut right through all the noise.
Okay, so here's the game plan. We're going to systematically break down oxygen therapies, then jump into acute illnesses like croup and bronchiolitis, and finish strong with chronic conditions like asthma and cystic fibrosis. Think of it like your ultimate pre-exam cram session.
First things first. Before we can even really talk about the specific diseases, we have to master the basics. You know, the tools of the trade. That means understanding oxygen and inhalation therapy from Chapter 16 of your ATI book.
It all starts with our assessment, right? And pulse oximetry is our best friend here. It gives us that vital SaO2 reading, non-invasively. Now, that expected range, 95 to 100%, you've got to burn that number into your brain. It is fundamental for the exam.
So here's the million-dollar question, and you know ATI is going to ask this. Your patient's SaO2 drops below 91%. What is your very first move? Before you crank up the O2, before you even think about calling the doctor, you check your equipment. Is that little sensor probe on the finger correctly? Is the tubing kinked? Always, always, always assess your equipment first.
And check this out. Each delivery system has its own little safety quirk you need to know. For an infant and an oxygen hood, you absolutely must have a flow rate of at least 4 to 5 liters per minute. Why? To flush out the CO2 so they don't rebreathe it. For a face mask, that number jumps to 5 to 10 liters. These are the kinds of specific numbers that show up as exam questions.
Now, oxygen is obviously life-saving, but it's a classic case of too much of a good thing. Oxygen toxicity is a serious risk. You've got to be on the lookout for these signs, especially things like a non-productive cough, nasal stuffiness, and, kind of paradoxically, hypoventilation. Our goal is always to use the absolute lowest oxygen level that still keeps that SaO2 in a safe range.
All right, let's switch gears and talk about the stuff that brings kids into the ER, the acute illnesses from Chapter 17. The name of the game here is differentiation. ATI will absolutely test your ability to tell these high-stakes conditions apart, even when they look similar at first.
Okay, if you're going to screenshot one thing today, this is probably it. Croup versus epiglottitis. You have to know this table inside and out. Croup gives you that classic seal-like barky cough with a low-grade fever. Epiglottitis, it's the total opposite. Think high fever, and this is the key, the absence of a cough. Instead, you're going to see that tripod position, drooling, and a whole lot of agitation. And let me be perfectly 100% clear on this. Epiglottitis is a drop-everything-and-run medical emergency. It's a life-threatening situation. If you even suspect it, you're getting ready for intubation and you're keeping that child as calm as humanly possible. The number one rule, do not, I repeat, do not put anything in your mouth or try to look at their throat. You could cause a complete airway spasm.
Okay, another big one you'll see all the time is bronchiolitis, which is usually caused by RSV. The key here is to recognize how it progresses. It starts out looking just like a common cold, runny nose, some sneezing, but as it gets worse, that's when you see the increased coughing, the retractions, and just tons of mucus. And the real red flags for severe illness? A respiratory rate over 70, periods of apnea, and any cyanosis. That's a kid who's in big trouble.
All right, so we've handled the emergencies. Now let's switch gears and talk about the long game, the chronic conditions from Chapters 18 and 19, asthma and cystic fibrosis. For these, the exam focus really shifts to long-term management and especially patient education.
First up is asthma, and here's the textbook definition straight from your ATI book. But what are the key words you really need to latch on to? For me, it's chronic, inflammatory, and the most important one, reversible. That reversibility is key to what makes asthma, asthma.
You can pretty much guarantee you'll get questions on this. Teaching patients and families how to use a peak flow meter is a huge nursing role. You have to know these zones cold. Green means go, everything's good. Yellow means caution, time to use those maintenance meds. And red is a medical alert. That means use the rescue inhaler right now and get help.
Now listen up, because this is a super important assessment point that feels totally counterintuitive. We all associate asthma with wheezing, right? But what happens when a child in severe distress suddenly stops wheezing? That's not a good sign. That is a 5-alarm fire. A silent chest means air isn't moving at all, and that means respiratory failure is right around the corner.
And that leads us to the worst-case scenario for asthma, status asthmaticus. This is that terrifying situation where a severe attack just isn't responding to the usual treatments. As a nurse, your priorities are going to be continuous monitoring, giving high-dose nebulizers, IV steroids, and always being prepared for intubation.
Okay, our next chronic condition is cystic fibrosis. The one thing, the absolute hallmark of this disease that you have to remember is thick, sticky, tenacious mucus. It's that mucus that's the root of all the problems, causing blockages everywhere.
And this is so crucial to understand. CF is not just a lung disease. A lot of people think that, but it's a multi-system disorder. That thick mucus doesn't just clog the lungs, it gums up the works in the pancreas, which means digestive enzymes can't get out. This leads to malabsorption, fatty stools, and failure to thrive. It impacts just about every system in the body.
So the big question is, how do we manage all that mucus? It's all about airway clearance techniques, or ACT. But look at the order here, this is key. You always give a bronchodilator before you start chest physiotherapy. Why? You want to open up those airways first so the CPT can actually be effective and get that mucus out. And finally, how do we get that definitive diagnosis? Well, it all comes down to one test and one magic number, a sweat chloride test. For any kid over 3 months old, a result greater than 60 confirms CF. This is one of those straight-up memorization facts you just got to know for the exam.
Okay, take a deep breath. We have been through a whirlwind of information. So now let's boil it all down to the absolute, high-yield, must-know points that you need to walk into that exam with. This is your final, rapid review.
Ready? Here are your top 5. Number 1. Your patient's O2 sat is low? Check the probe first. 2. Epiglottis means drooling, no cough, and it's an emergency. Do not inspect the throat. 3. With asthma, a silent chest is way scarier than a wheezing chest. 4. Know your asthma meds. Albuterol for rescue, fluticasone for maintenance. And 5. For CF, think airway clearance and giving those pancreatic enzymes with every single meal and snack.
Okay, so I'm going to leave you with one final clinical scenario to think about. You walk into a room, you see a kid with stridor. Nasal flaring, retractions, they are clearly in distress. What's your gut reaction? What is that priority nursing action that's popping into your head right now?
Listen, you have been studying so hard for this. You know this stuff. Just take a deep breath, trust what you know, and go in there and crush this exam. You've absolutely got this. Good luck!